In the high-stakes world of retinal diagnostics, a single clinical misinterpretation of symptoms can lead directly to irreversible vision loss. Yellowish macular deposits and pigmentary changes trigger an immediate reflex, early AMD. But that's a trap. 2 of these patients actually have high-risk phenotypic mimics. Relying solely on pattern recognition and the surface appearance of the fundus leads to severe clinical mismanagement. Treating these alternative pathologies as standard AMD allows the actual underlying diseases to progress unchecked. Clinicians must first filter their observations through a critical demographic anchor, age. True age-related macular degeneration is defined by cumulative metabolic failure over decades. Because this process is time-dependent, drusen-like signs in a patient under 50 indicate a non-age-related phenotype that requires immediate specialist referral. To accurately identify and manage these non-AMD macular diseases, practitioners must use multimodal imaging to isolate specific structural and demographic biomarkers. Surface-level diagnostics leave too much room for error. Surviving the clinical minefield of macular disease requires deconstructing the retina, layer by layer, to unmask the true underlying pathology. The first major imposter is idiopathic central serous chorioretinopathy, or CSC. Unlike the structural decay of AMD, CSC is a fluid-driven pathology. Its classic demographic presentation points away from the elderly. We typically see CSC in younger to middle-aged males, particularly in Asian populations where multifocal forms are common. The onset is often linked to psychogenic and pharmacological triggers. Corticosteroid use is a primary culprit, alongside extreme psychological stress and patients exhibiting highly tense type A personalities. This diagram illustrates the defining pathophysiological marker of CSC, a serious elevation of the neurosensory retina. A pocket of fluid accumulates and physically pushes the top layer upwards, separating it from the flat retinal pigment epithelium below. Contrast this structural anomaly directly with standard AMD. On the right, typical AMD features rigid drusen forming underneath the RPE layer. On the left, CSC fluid buildup occurs entirely without the presence of drusen. The danger of CSC lies in chronicity. If that subretinal fluid persists for 3 to 4 months, it starves the outer retina of necessary nutrients and physical contact. This extended detachment causes severe photoreceptor outer segment wasting and a complete loss of the RPE's structural integrity. Eventually, this results in RPE atrophy. Clinically, this end-stage atrophy looks virtually identical to atrophic AMD, creating a dangerous diagnostic trap if the patient's history is ignored. There is a critical demographic exception to these rules. Practitioners must exercise extreme caution when diagnosing CSC in older Caucasian females. In this older demographic, what looks like CSC has a very high risk of actually being a neovascular complication, specifically polypoidal choroidal vasculopathy. Differentiating CSC from AMD requires tracing macular atrophy back to its exact timeline of fluid exposure. Chronological history provides context that structural imaging alone cannot. Our second major imposter category is the inherited macular dystrophies. These present with distinct clinical hallmarks. Because most are inherited in an autosomal dominant manner, they carry a strong family history. Structurally, the presentations are typically bilateral and highly symmetrical. This image is a fundus autofluorescence, or AF scan. It is the mandatory investigative tool for identifying these inherited retinal diseases. AF works by mapping metabolic stress. The intensely bright patches you see indicate increased background hyperautofluorescence, which signals a widespread genetic RPE dysfunction rather than localized aging. 2 prominent examples are Best's disease and adult vitelliform dystrophy, or AVD. Best's usually has a pediatric onset with massive subfoveal lesions, but AVD poses a much stealthier threat. AVD often presents in patients over 50. It features small, yellowish lesions that perfectly mimic the appearance of standard AMD drusen. The primary differentiator between AVD and AMD is topography. In typical AMD, drusen scatter diffusely across the entire macular region. AVD lesions, however, are rigidly localized directly under the fovea. Isolating this subfoveal geographical constraint exposes the hidden genetic dystrophy that fundoscopy obscures. This brings us to the most deceptive mimic of all, the inherited drusen phenotypes. the presence of actual drusen on an exam does not guarantee a diagnosis of standard AMD. Consider cuticular drusen. Clinically, this presents as highly symmetrical, densely packed, small round drusen, typically in patients aged 40 to 60. Differentiating this specific condition requires optical coherence tomography, or OCT, to closely analyze the physical architecture of the deposits. Look at this simulated OCT scan. A standard AMD drusen forms a distinct, localized deposit underneath the RPE layer, causing it to bulge upward in a wide, rounded bump. Cuticular drusen is entirely different anatomically. It is not an isolated sub-RPE deposit. Instead, it is a diffuse thickening of the RPE basement membrane itself. This membrane thickening produces the pathognomonic sawtooth pattern on an OCT scan. Those sharp, jagged peaks are the definitive architectural biomarker for cuticular drusen. Another highly concerning phenotype is early-onset drusen. Finding drusen in a young patient triggers an absolute systemic mandate. Early-onset drusen is heavily linked to severe systemic issues, particularly renal pathologies. Any presentation of these deposits in a younger demographic requires immediate urinalysis to screen for broader physiological breakdown. The microscopic geometry of a deposit dictates the stakes. It tells the practitioner whether they are monitoring an isolated aging eye or intercepting a systemic multi-organ disease. Let's return to the 3 ambiguous cases from the initial clinical trap. Applying our multimodal biomarkers breaks the illusion of similarity. The sawtooth OCT pattern reveals cuticular drusen. FAF mapping uncovers the genetic stress of AVD. Only the final image is standard AMD. The consequences of failing to make these distinctions are severe. Misdiagnosing CSC or Best's disease as early AMD means missing critical windows to treat aggressive neovascular complications. Treating early-onset drusen as standard wear and tear leaves the patient vulnerable to undetected renal failure. This reinforces the ultimate clinical defense, the triage rule. If the patient is under 50 and presents with macular deposits, refer them immediately. Beyond that, practitioners must utilize FAF for baseline genetic screening and dissect OCT architecture to locate the precise layer of fluid or deposition. As these varied macular diseases progress toward end-stage atrophy, their physical appearances converge. Differentiating them late in the disease process is nearly impossible, making early, accurate biomarker identification your only defense. In advanced ocular diagnostics, superficial pattern recognition is a liability. True disease management is built entirely on a foundation of first principles structural analysis.